for this meeting has begun.
Good morning or afternoon, I guess we're heading into. My name is Jordan Friend, and I'm with the Office of Continuing Medical Education at the School of Medicine. Welcome to the webinar today. We're going to move on to our next page where I can show you our exciting event today. Here is our CME accreditation and designation for those of you getting CME for today. Here's the information that you need to know. And today you're going to have Paul Snyder as your speaker. He's incredible. He's highly knowledgeable in this area. And so he's going to be talking to us about substance use disorder. So without a further ado, Paul, it's all yours.
All right. Thank you very much, Jordan. Thanks, everybody, for being here. Lots of people came together to put this presentation on. We have University of Reno School of Medicine. That's the team over here with Jean and Jordan and Jen. And JTNN, that's Joined Together Northern Nevada, who put together this educational series and partnered with Hazel and Betty Ford, who brought together vignettes. This vignette today is from Sharon Levy from Harvard Medical School, so big thanks to her and all they do. So my name's Paul. I'm a licensed alcohol and drug counselor supervisor. And in looking at this subject, we have a lot of attention going on with opioids and other chemicals now. But when we're looking at methamphetamine and psychostimulant drugs, we have to remember that Nevada has the highest death rate related to psychostimulants and state death rate ratio from 2005 to 2009. That's a study that was done for 15 to 64-year-olds. So you take everybody who's died from psychostimulants, and they figure out which state is most prevalent, and that's us over here in Nevada. So we're going to be looking at amphetamines, we're going to be looking at methamphetamine, and then the vignette shows a person who's actually struggling with some issues, and we'll go through that. When we're looking at stimulants, we have to look at what NIDA says. Stimulants increase alertness, attention, and energy, as well as elevate blood pressure, heart rate, and respiration. So as opioids is the downer, stimulants, the upper, is elevating that blood pressure. So stroke and heart attack are the main reasons for someone overdosing with these medications. All stimulants work by increasing dopamine levels in the brain. Dopamine, as you know, is a neurotransmitter associated with pleasure, movement, and attention. We also have to remember that it increases serotonin and noradrenaline at the same time. So we got a triple bang effect here. Stimulants historically were used to treat asthma and other respiratory problems, obesity, neurological disorders, and a variety of other ailments. But as their potential for abuse and addiction became apparent, the medical use of stimulants began to wane. Now stimulants are prescribed to treat with only a few health conditions, mostly ADHD, but there is some narcolepsy and occasionally depression in those who have not responded to other treatments. So when we're looking at ADHD, we have to, I'm going to be talking about Adderall. Okay, I'm going to be talking about Adderall simply because the vignette talks about it, and it's one of the main stimulants that's prescribed. And we have to remember that Adderall is indicated at the beginning. Age is 3 years old, so 3 to 5 years old. That's 2.5 milligrams. It's the indication. So when you're looking at the diagnostic criteria for ADHD, it's real easy to see where somebody who's a toddler could get into meeting the criteria for ADHD. So inattention is the first criteria. So we're looking at impulsivity and distractibility as the two criteria for ADHD. So first one is inattention, and that's for people who are 17 and younger. So 6 or more of these symptoms must be present for 6 months, inconsistent with child's developmental level. So we have to remember where the child is on their development. And also when we're looking at developmental levels, we recognize that age 2 and age 11 is where they're having a literal dendrite explosion in their brains. These are huge growth areas, both physically and mentally, for these little people. And so we have to recognize, is this normal developmental issues, or is this something that requires more observation? They need to have a negative effect on their social and academic activities, and to be endorsed, the following must occur often. So failure to pay close attention to details, have trouble sustaining attention, doesn't seem to listen when spoken to directly, failed to follow through on instructions and failed to finish schoolwork or chores, has trouble getting organized, avoids or dislikes doing things that required sustained focus and thinking, loses things frequently, easily distracted by other things, and forgets things. This is hyperactivity impulsivity, and so we're looking at 6 or more of these symptoms must be present for 6 months and inconsistent with the child's developmental level, have a negative effect on their societal and academic activities. And again, this is often, and so that's very subjective. So fidgets with their hands or feet or squirms in their chair, frequently leaves the chair when seating is expected, runs or climbs excessively, trouble playing or engaging in activities quietly, acts is on the go and if driven by a motor, talks excessively, blurts out answers before questions are completed, trouble waiting or taking turns, interrupts or intrudes on what others are doing. I hit most of the criteria for the hyperactivity impulsivity, but I haven't been diagnosed with this yet. Okay, heavy on the yet. Okay, Adderall contains a combination of amphetamine and dextroamphetamine, central nervous system stimulants that affect chemicals in the brain and nerves that contribute to hyperactivity and impulse control. And it's a combination medication that works changing the amounts of the certain natural substances in the brain. It can help increase the ability to pay attention, stay focused on an activity, and control behavior problems. So it is effective in 80 to 90% of the people who take Adderall. They report that it does work. It may also help the patient to organize tasks and improve listening skills. Adderall is used to treat narcolepsy and ADHD. So let's look at these side effects. Now, I'm going to be going through side effects with meth too, and see if you can recognize any of the side effects that are consistent, possibly just at a lower level, but still represented. So one of the side effects for Adderall is growth in children. So that's something to be concerned about if this is something that you're choosing to prescribe. Chest pain, trouble breathing, feeling like you might pass out, hallucinations, seeing or hearing things that aren't real, new behavior problems, aggression, hostility, paranoia, seizures or convulsions, numbness, pain, cold feeling, unexplained wounds or skin color changes, pale red or blue in appearance in your fingers or toes, muscle twitches, changes in your vision. You know, going back to this numbness, we have to remember skin is an organ. It's our largest organ. And all of these stimulants take their tolls on organs. unexplained muscle pain, tenderness, or weakness, especially if you have a fever, um, unusual tiredness and dark-colored urine, stomach pain, loss of appetite, loss of weight, mood changes, feeling nervous, fast heart rate, there it is, headache, dizziness, sleep problems, insomnia, or dry mouth. So, the thing is that as far as stimulants go, when we're looking at older people, for example, they want to take a test, they're not doing too well, one of their friends gives them the opportunity to try some Adderall or Ritalin, whatever they have, some speed, and they say, okay, so they take it and it works, like we were talking about before, and they feel good. The problem is, depending on what level they took, they can't turn it off when they want to. So say they take extended release. Well, that's going to go on for 14 hours. And so if they want to study for that test, and after they're through studying about 3 or 4 hours, they want to turn it off, they're still up at 3 or 4 in the morning because it's still having its impact. It's still having that cascade effect on all of the chemicals that are being released. So the problem also is when I'm seeing students is that they tried it for a test, it worked, they were excited about it, say they got the result that they wanted, but then they have more than one test, and so they took it for the next test, and then the next test, and then eventually it just became part of their study habits until they have a really difficult time getting off of it. Methamphetamine. So this is what happens with methamphetamine. It attaches to dopamine receptors, and the body lacks the enzyme to break down the methamphetamine on these receptors, so the impact is much longer. That includes the highs. That's for like 10 hours to 4 days. And so you hear these stories about people who are taking meth, and I see it a few times every week, where the person is just devastated mentally. It's really apparent physically and emotionally. And people, when they see them, wonder, how could you possibly be taking this drug when it makes you look like that? You have a mirror, you have access to stuff. Why your teeth look like really bad, your skin is horrible, you're just a mess. So why do you do that? Well, when we're looking at addiction, when we're looking at treatment, we're looking at not making bad people good. We're looking at making sick people better. And the idea with amphetamines is, especially meth, is it has a really high dopamine release, like we were talking about before. So let's put this into perspective. So say you're cruising around, you're feeling pretty good, your basal DA output's around 100, doing well. And you introduce food, you're hungry, it's around lunchtime, you're probably eating right now, so you have your sandwich and spike up to a 50. That's 150, nice little spike there. So tells your brain, you know what, this dopamine release is set up so that we can biologically survive, and it helps motivate us through life, letting us know what's good and what's not good for us by feeling. So we eat the food, we get that spike, we're feeling good, we remember it, and we're going to do that again. Same thing happens with water. Sex is another one. So we get all these dopamine releases throughout our life, and for sex, that's around 2.25. That's for procreation. That's to keep the species going. We've been wired and trained internally to say biologically this is an important activity, so we're going to get more and more dopamine. Now, when we look at dopamine release with amphetamines, remember food was about 50, sex is about 2.25. Meth is up to about 1,100. That, my friends, is what keeps people coming back. And it's a very quick release. So when people have the choice between having meth or something else that might make them feel good, or what we consider healthy alternatives, like playing basketball or being with friends, there is no way that they can compare to the dopamine release and the chemical release of serotonin and the noradrenaline that they can get with meth. Now, here's the thing with amphetamines too. This does not take effort. Everything else, when they were younger and before they were exposed to this kind of dopamine release, everything else took effort and took time and energy and thought to get that release. Now they can get it without any effort and with a simple pinprick or snorting or smoking. They can have access to this, which takes very, very little effort. Cocaine, we'll move on to the next little slide here. You can see that is a pretty good draw too. That's about 350. Nicotine. Nicotine's also a stimulant. You know, everybody is down on nicotine because of the cancer that is an after effect. However, as a drug, you're getting up there around the 2.25 mark for dopamine release. It's also great for keeping you detail oriented and keeping people with keeps their attention. Morphine. Morphine's up around that 200 mark, and heroin is actually a little bit higher, but whenever you're doing a drug screen, if it's heroin or most other opioids, the screen is going to show positive for morphine. That's what it breaks down to. So it's all about the dopamine. So let's look realistically. I've been talking to my my meth patients, and I can get a lot in books about what they're feeling, but firsthand, what they're reporting is we're looking at their eyes, and that's one of the first things that they talk about. One lady, she said she felt so much pressure in her eyes after being up for 3 days that she had to put cotton balls on over her eyes and then tie it as tight as she could with a handkerchief just to try to keep the blood pressure down. Her eyes are blurry from having dilated pupils. If you can imagine having dilated pupils for more than when you go to the eye exam and get your eyes dilated, we're talking about days upon days. And they get yellow colored, they get strained. And interesting enough, the world gets a gray tinge to it. Also, they tend to gravitate towards basements so that it can be cooler and darker. And it's also good for that paranoia that sits in, because they're not going to see very many. There's not going to be very many windows down there. Flaying arms. So if you see somebody who's actively on meth, their arms, they can't keep those down. They're moving their jaw back and forth, grinding, clenching their teeth. Their hands and feet get stuck. They have cramped fingers and toes simply because they're dehydrated and they get stuck, where it's really difficult to get out and get those cramps worked out when they're as dehydrated as they are, and seizures. All about dehydration. Their muscles ache all over. Your joints, knees pop, bones ache, spine really hurts because it needs rest, and they've been up for hours and hours just doing meaningless tasks. They have extreme paranoia. So you'll hear stories or actually watch them checking the door, the window, the phone, always looking around. Computer and the phones are a big distraction. You spend 6 hours changing the settings on their phones, but then if they still have their phones after, if they can still remember where their phones are after they've been running around for this many days, then they have a really hard time getting into their phone because they forgot what the setting was because they've been overthinking all of their settings. You don't care about anyone. or anything, no morals or values, habitual liars, um, chasing with a vengeance, fiending. That's a big word. If you hear the word fiending, it's actions just as you'd imagine. It's acting like a fiend going around trying to get whatever you can to get more of that dopamine release. And dangerous. They have a greasy feeling. Toxins are being released through the skin, and that feels itchy. They also feel like sometimes they have bugs under their skin. And in the short term, you have that euphoria, paranoia, increased energy, increased irregular heartbeat, decreased appetite, and increased libido. Uh, Stimulants are notorious for that increased libido. So they would prefer to have their drug of choice, but that's not saying they're not going to do other things with that. So if they can try to increase that dopamine release, they will go for it, and this is one of the ways that they can accomplish that. Long term, they develop a heavy and quick tolerance, insomnia, agitation, psychosis, extreme weight loss, violent tendencies, acne, and meth mouth. So yeah, there's my meth mouth. We'll just jump down to meth mouth. The reason people get meth mouth is because they're running for so many hours without saliva. They've impeded the flow of saliva through their meth use, which can't wash away any bacteria or natural acids which accumulate and eat away at the enamel and gums. And the roof of the mouth also feels scaly and dried out. Plus, they're not brushing, flossing, going to the dentist. So when they're in withdrawal, I'll go back to the top now, they're craving more methamphetamine. They sleep, and this sleep is not natural 4-stage REM sleep. They're coma-like sleep, and this is for days. So if they go on a bender for 3 or 4 days, their sleep is going to want to get caught up, and that's going to cost them about a day, day and a half of just sleep. Anger and rage at everyone but themselves, physical pain all over their body, and nausea. And one of my people was telling me that her eyelashes hurt, her eyebrows hurt, everything hurts and is cramping up. She's feeling sweating, things are crawling all over her skin. She has this extreme nausea. She knows she needs water, and she can't even get out of bed to get water. Hair loss, shaking and tremors. So Parkinson's disease is 3 times more likely with meth users. Heart palpitations, respiratory failure, coma, and death. So these are the outcomes. The good news is treatment works. And so the reason for that is I wanted to give you an idea of what they're going through when they are when they're held captive by this monster called meth. So now we're going to go over to Dr. Levy's vignette, where she has she's working with the intern and Dr. Coos, we'll just call him Dr. K. The attending physician has asked you to take the history of the next patient. This is Mr. Crowan, 34-year-old male, who was referred from the emergency department for follow-up of an infected lesion that was treated with a course of antibiotics. A set of blood tests, including liver function tests, were within normal limits. You enter the exam room and find that Mr. Crowan is very thin. His face is drawn and parked with a number of pit-like lesions, various stages of healing. He appears anxious. So first thing that you see here, he was at the emergency department for infected lesions. So that could be a red flag for you. You introduce yourself and say, so what brings you in today? He's pointing to his face, this. That could be a red flag. Are there any other places in your body that are affected? My arms and his torso. So he's got several more excoriations, um, and he's feeling pretty bad about these bites, what he's calling bites. So you tell me how it started. He says, everything was fine until I lost my apartment, there's a red flag, and had to move to an awful place, there's a red flag. Pretty soon after I moved in, I developed these itchy patches on my skin. So what caused him to have to move into this place? And when we're thinking about lower economics, this is something that we have to be aware of. I try not to scratch them, but I can't help myself. I know it's bed bugs. I could feel the things crawling all over me. I had to scratch, and sometimes I break the skin. A couple of weeks ago, one of the sores became painful and really red and was draining pus. I went to the emergency department, and they told me the sore was infected. They gave me some antibiotics, and it seemed to work. They wanted me to see the dermatologist, so here I am. You review his history and find it's only remarkable for heart problems. Okay? So we got a stimulant. There's your heart problems several years ago. He elaborates, I was having episodes of chest pain, but they weren't heart attacks. I think they were panic attacks. So cocaine and cardiovascular. You step out and quickly present the case to Dr. K, who notes, something here doesn't seem right. The good doctor says, people do not generally feel bed bugs. I'll be ready to see him in a few minutes. In the meantime, see if there's anything in the medical record about his chest pain. You look up Mr. Crone's past emergency department visits and find 3 events in the span of a few months when he was 29 years old. He presents with chest pain, tachycardia, and hypertension. Each time his labs were normal except for drug tests that were positive for cocaine. His discharge diagnosis was cocaine-induced chest pain. So here's the question. What are the cardiovascular effects of cocaine? Give you a couple of minutes. Go ahead and fill that out. Oh, good. Everybody got that. Cocaine does not cause hypotension. It would be hypertension. So cocaine is a sympathetic mimic drug that causes heart rate and blood pressure elevations. It's also a vasoconstrictor, and there's evidence that cocaine can cause vasospasms in the coronary arteries. When cocaine is taken in combination with alcohol, a compound called cocoethylene is formed in the blood. Cocoethylene is a longer half-life than cocaine alone, may cause platelet aggregation, which also increases the likelihood of ischemic events. So, causes vasoconstriction, causes coronary artery vasospasms. We got that cocoethylene, and can cause tachycardia, so that heart beating faster. Screening. Okay, so you tell Dr. K what you learned. He explains that going on drug use may be related to that ongoing drug use may be related to skin lesions. You and Dr. K go in to see Mr. Crone. After introducing himself and verifying the history with Mr. Crone, Dr. K asks, I wanted to learn a bit more about the chest pain episodes you had when you were 29. I was working like a fiend. Oh, there's that fiend. In a very stressful job. So there's your red flag fiend. I started getting chest pain, and they told me I was having panic attacks in the emergency room. So chest pain, going to the emergency room. I noticed that you also tested positive for cocaine during those episodes. Can you tell me more about your cocaine use? Well, I was living a work hard, play hard lifestyle. So when somebody says work hard, play hard, sometimes their impression of themselves is all-in kind of guys or gals, and they want to suck the marrow out of life, and sometimes that work hard, play hard is a code for kind of a reckless lifestyle. I was using cocaine a lot back then. How about other drugs? How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? They asked that question very well. And you'll see that in the drug use screening question. It's not fool around with it. It's not worry about hurting their feelings. When I'm doing an evaluation or going through criteria, I usually ask, what else? What more? Okay, can you tell me more? And after they get used to um, feeling safe with you, then they're going to um, divulge more and more about really what's going on with them. And so the single question, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons, it's very sensitive for identifying patients with drug use disorders. The question has been tested in research trials and should be asked exactly as it is. Whenever this screen is positive, further questions should be asked to assess whether the patient has a drug use disorder. So, symptoms of cocaine use. Are you guys already jumping ahead? It looks like you are. Okay. So, very good. Okay. Outside of the room, Dr. K says there are medical conditions that can cause people to excoriate themselves. But given his normal labs and the rest of his history, I'm wondering if drug use is the cause of this. There you go. Additional symptoms of cocaine use, and you all got them correct. This is a smart group. Euphoria, yep, it's pupillary dilation. Hallucinations, formication, insomnia. Okie dokie. So Dr. K examines Mr. Crohn's skin thoroughly. There are multiple excoriated sites in various stages of healing on his face, arms, and torso. He summarizes, the good news is that none of these areas look infected. I don't think this is from bed bugs, as bed bugs bite usually have punctum, a small spot in the center. I don't see that on you. Have you been itchy? The marks look like scratches. I don't see rashes underneath. Yes, Mr. Crohn exclaims, I've been very itchy, and I can actually feel the bugs crawling on me. Is there something else that can feel like that? There's a couple of things that can do it. One of the most common is drug use, Dr. K explains. So, you take the drug use history. You said before that you use drugs once in a while. Can you tell me a bit more? Actually, I use cocaine once in a while, but it's no big deal. It's just recreation, nothing like before. But how often would you say you use cocaine now? Maybe once or twice a week. I don't use it every day. How about other drugs? Do you use anything else? I smoke marijuana once in a while, maybe once a month, but that's about it. How about medications? Do you ever use medications that were not prescribed to you or more than was prescribed? Every now and then, my friend gives me some of his Adderall. So when we're looking at mechanisms of actions of stimulants, cocaine and amphetamines are stimulants with similar physiologic effects. Both substances cause increased levels of dopamine and norepinephrine in the synapses between the neurons. Cocaine is an alkaloid that is derived from the leaves of the cocoa plant and inhibits neural reuptake of dopamine and norepinephrine. So we're looking at the dopamine is also the ability for it to reuptake. So when it's blocked off from reuptake, the person's just getting a cascade of all of these chemicals that is not being released or recycled back into the vesicles. Amphetamines causes the release of dopamine and norepinephrine from vesicles and also inhibits reuptake. They're available pharmacologically either as a racemic mixture of both levo and dextrose salts, so that's Adderall, or as a dextroisomer, dextroamphetamine, that's dexedrine, which has more specificity for the dopaminergic effects compared to the levoisomer. So Vyvanse is a prodrug which the body converts into dextroamphetamine. Now, methamphetamine is also available. Amphetamines are commonly used for the treatment of attention deficit hyperactivity disorder, like we talked about before, and in the treatment of certain sleep disorders such as narcolepsy. Illicit methamphetamine produced in illegal laboratories or imported from abroad is commonly abused drug in the United States. So administration of a stimulant. What are the routes of administration of cocaine and amphetamines? How'd you do? Boom, boom, boom. Can be taken orally. You know what? You are correct. It can be taken orally, although the expert here says you can't, but you can. If you mix it, you're only going to get about a third of the product in your system because it has to be metabolized through the liver, and before it gets in there, you're only going to get between 30 and 60% of the impact of the amphetamine. So we all got 100. Congratulations. Okay. Amphetamines can be taken orally. Yes. They can be inhaled and they can be taken intravenously. Cocaine can also be taken orally, even though they say that it can't. It can. They can also, well, there's a lot of different ways they can put it into their persons. Effects of the stimulant drug administration route. The faster the drug reaches the brain, the quicker the onset of action and the greater the liability for addiction. So when somebody smokes something, when they smoke it, they're losing about 75% of the drug into the atmosphere. So that's what leads them to snorting it or to actually putting it in their veins. When substances taken orally have a slower onset of action because they must be absorbed and pass through the blood system before reaching the brain, and substances that are inhaled or smoked are absorbed through the pulmonary vasculature and reach the brain quickly. Intravenous use results in the quickest onset of action. Cocaine comes from a powder form that can either be snorted or taken intravenously. Powder cocaine cannot be smoked because of its high burning point. Freebase cocaine and crack are forms of cocaine that can be smoked, so that's just adding liquid to it, and then you have to clear it out from its impurities. When it's been stamped, it has a lot of different impurities on it, and so you pure it up, you put some liquid in there. That's how you'd be freebasing it. So resulting in a quicker onset. Cocaine is occasionally applied to oral mucosa. You see people who put it over their teeth, resulting in a local sensation of numbness, but we could ingest it orally. Amphetamine pills can be taken orally, which is how they are prescribed, or crushed and snorted. Methamphetamine can be snorted, smoked, or taken intravenously. SUD criteria. So let's go down to this chart at the bottom here. We have substance use disorder criteria. These are the 11 criteria that people will use to create a diagnosis of mild, moderate, or severe. Remember in DSM-4, previously we had abuse and dependence, and now we have mild, moderate, or severe. So the way this works is you just look at the substance use disorder and you switch it up, take that substance out and put alcohol in there, or put stimulant, or put marijuana, or put heroin or opioid use disorder. So you just switch out the substance with whatever substance you're looking at. Then you go down these 11 criteria. Now, if they hit one or two of these, or two or three of these criteria, they're considered to have mild substance use disorder. 4 to 5 is moderate substance use disorder, and 6 or more are severe substance use disorder. So for sake of argument here, we'll look at this young man and we'll say, okay, so taking amphetamines in a larger amount or for a longer period than you meant to. I'd say he probably hit that. Wanting to cut down or stop using amphetamines but not managing to. Sounds like he hit that. Spending a lot of time getting, using, or recovering from its use of amphetamines. Sounds like he did that. Craving and urges to use the substance. I think he has cravings. Not managing to do what you should at work, home, or school because of amphetamine use. Continuing to use even when it causes problems in relationships. Giving up important social, occupational, or recreational activities because of amphetamine use. Using amphetamines again and again, even when it puts you in danger. Continuing to use amphetamines even when you know you have physical or psychological problems that could be caused or made worse from the substance. Needing more of amphetamines to get the effect that you want, that's tolerance. And developing or withdrawal symptoms which can be relieved by taking more of amphetamines. So, if you had to say, has he met 2 or 3 of these criteria, would you say yes? Probably. You think 4 to 5? If he hit 6 or more, we're in severe substance use disorder. Now keep in mind, when we're doing these criteria, you have to take into consideration a lot of different things. One is the skill of the clinician who's asking the questions. How are they asking it? Have they created a safe environment where the person feels that they can be honest with the clinician? Can they remember everything that they've done? Are they embarrassed? Are they disclosing everything? And the thing about treatment is we get this to create a baseline, not to label people. But once we get this information, the whole idea is to get this these criteria to change, to move them through the stages of change where all of these will eventually, hopefully, go away. So let's go back up to Dr. K. He's taken that substance abuse disorder history. Can you tell me about how you take Adderall? Initially, I was swallowing it. I thought it might help me do my job better. After a while, I felt like it wasn't working anymore, so I started crushing it and snorting it. Okay, so you usually don't do that for therapeutic reasons. The reasons you're doing that is to get that feeling. Truth is, it gave me a buzz, there it is, and I started using more. When my friends stopped selling it to me, I started to use cocaine again. So he's a feel-good junkie. That's his drug of choice. However, he'll go to the second one if it's available. Have you ever had symptoms of withdrawal? Yeah. My friends stopped selling it to me and I felt terrible. I was tired and depressed. I just couldn't get out of bed. Do you crave Adderall or cocaine? Sometimes. I find myself dreaming about getting high. These dreams are a really big telltale sign, and they usually go away. But in the beginning of treatment, when they're going through their healing process, dreams are a big part. You always hear about dreams. Would you say that you often end up using more cocaine and Adderall than you intended? I guess so. I mean, I get started and I can't stop until it's all gone. So let's see this diagnosis here. Mr. Crowan meets criteria for severe stimulant use disorder. So pat yourself on the back if you gave him 6 or more. Dr. K explains to him that his itchiness and the sense that he has bed bugs crawling on him are a symptom of stimulant use. The only way to make it go away is to quit using cocaine and amphetamine. That's the beautiful thing about the body and the brain. Very resilient organs. They want to be healthy. It's the addiction that has them circling the drain, but the body will bounce back, as will the brain, in a relatively quick amount of time if there hasn't been permanent damage that's been done through use. You said that 6 years ago you decided to go to a treatment program for cocaine use. Can you think back on that and tell us the reasons you decided to go? Mr. Cronin replies, I had really lost control of cocaine use. Okay, so he's gone to treatment and he's relapsed again. Sometimes, statistically, 50% is a good marker for people who go to residential treatment and see success. And success being defined as 1 year without using the substance. If somebody goes to treatment, one of the next questions is, how many treatments did you go to and what were they for? So when he's replying, I had really lost control of cocaine use, I lost my job, I was always out of money, and then I started getting the chest pain, I knew I had to do something. So that's kind of his rock bottom. Drug use can really get out of control pretty quickly. It sounds like you made a good decision to go into treatment. How was it for you? The good doctor asks. And that's a wonderful way to build an alliance and help that patient know that you are on their side. You're not punitive, you're therapeutic. Usually, especially with amphetamines, they're so paranoid that everyone is going to be looking out to get them that it's very refreshing when they find somebody who's on their side and whose motivation is to give them a hand or help them out. And that's also a way to get them into the appropriate level of care so that they can start on that road to recovery. Truth is that it wasn't fun, Mr. Cronin tells you, but it worked. I didn't use cocaine for a couple of years. I started using the Adderall because I thought it would help me do my job better. And then when I started using cocaine again, I thought I could control it this time. It really isn't as bad as it was the first time. I knew that I should quit, but I am pretty sure that I can stop on my own. If I go into treatment now, I'd lose my apartment and my new job. I just can't afford that right now. So you say, okay, I'm glad that you're willing to quit. It will definitely help your skin, and I'm sure it will improve your health and functioning overall. Most people find that treatment can be really helpful, just like you did last time, so that relating to them. There are a lot of different options. So the first one, they're saying no, and it's like, okay, I understand. So we're rolling with resistance and then offering up options that they can choose from. Everything from residential programs where you live for a few months while getting treatment to outpatient programs where you can come for a few hours a day or sometimes even less. It sounds like you're not interested in the residential treatment program right now. I'd really like for you to meet with a hospital social worker who can tell you more about the outpatient program and find something that will work for you. What do you think? That sounds like a good idea. Thank you, Dr. K. I was initially afraid of telling you about my drug problem because I thought that you would insist on sending me away, but I would appreciate help, and I'm glad to know that I have options. So if they've had experience with residential treatment, that's a big commitment. That's 24 hours monitoring and structure, and maybe they're not ready for that. However, if you do get them into treatment in an intensive outpatient program, which is 3 hours a session, 3 nights a week for 3 months, that can not only help them build their environment, get in with people who are also trying to stay sober, but then if they need more treatment, that's a great place to have those professionals move them into the appropriate level of care. So treatment works. The idea of amphetamines, I know we're on a big opioid kick now where everybody's spending a lot of resources on that. We can't let the amphetamines go to the wayside. We're seeing an awful lot of amphetamines, and it's very detrimental. However, if we catch it soon enough, we can help a lot of people. So let's see, how much time do we have? 10 minutes left. So I'd be happy to answer any questions or see what's on your mind.
Questions can be typed into the chat box at the bottom right.
Well, I'll give you a couple more minutes for questions, and if you need any assistance in setting up a treatment plan or setting up a referral system, please feel free to contact me. I'd be happy to help you find some help in that area and at least have somebody available to give you assistance if you do notice that somebody is struggling with any kind of addiction.
They are thinking about their questions. I'm going to move to the last page. This is the page that shows our evaluation. You're just going to need to browse to the evaluation and complete it. It will take you to your certificate page. But please feel free to ask questions here. Thank you, Paul, for your expertise. Thank you for presenting us with such good information.
Thanks, Jordan, and thank you all.